So I will talk about Taiwan's health system, and you tell me what you think when we have the free time. So I am here to talk about Taiwan's experience, but in a way, really, Taiwan, I would call it a younger brother of Canada. But it's gotten, this younger brother seems to have gotten very big, strong, kind of tough. Its name is the National Health Insurance. It's now 23 years old because it was implemented in 1995. So here is an outline. We're going to look at the genesis. How did it come about? And then we're going to look at how it actually works. And then we're going to look at the different aspects of its performance. And then, of course, challenges. You know, like everybody else, Taiwan's system has lots of challenges. Here's a brief overview of Taiwan. It's the numbers in parentheses in red, they're Canadian numbers. I thought I'd just put it there for comparison. You can see that Taiwan is smaller population-wise, but Canada is quite a bit older. Income-wise, per capita GDP, PPP, Taiwan is slightly richer, but Taiwan is spending a lot less per capita than Canada. And Taiwan also is doing a little bit better on infant mortality. And life expectancy, Canadians live, both men and women live a little bit longer. So, genesis. First, I'd like to talk about social values because that is something that is reflected in any country's health system. And in Taiwan's case, the value is expressed in the Constitution of Taiwan, Republic of China. Because the People's Republic of China, that is China today, it has its own constitution that's different. So Taiwan's, the Republic of China Constitution says, it's stipulated in there, is the government to provide social welfare shall implement social insurance institutions. And so this provided the constitutional mandate for social welfare programs. So it's a welfare state by statutory provision, and of which universal national health insurance is one. So in 1986, that's when Taiwan's government decided that they would bring about universal health insurance. Now, you know, the law can say whatever it says, but how do you deliver on that? And that brings us to this a very important thing, or concept in health policy, which is window of opportunity. You know, the conditions has to be right, the necessary conditions have to be there for you to be able to do a major program like that. So for Taiwan, the window of opportunity consists of the following factors, and these factors came together. There's a confluence of these conditions that came together that created the right time for it. First, there was a strong public demand for universal health coverage, and then there's political competition because Taiwan at that time had been a one-party rule for a very long time, for close to what, from 1950 to 1987. So that's 37 years of martial law where one party ruled. But then in 1987, the martial law was abandoned, and so political opposition came up. It became multi-party, but then one opposition party emerged as dominant. So they were vying for power for the presidency in Taiwan around that time. And the third factor, important, is you need money, right, to build a system like that, to deliver health care for everybody. Taiwan had great economic growth. In most years, it was double digits. So Taiwan went from a low income to middle income and very fast high income country, which made financing universal health care possible. And then I like to mention leadership, because the leadership recognized that here's an opportunity, we should do something, I mean the ruling party, and they seized it because they want to keep power, to stay in power. But then this president, Lee Teng-hui, he single-handedly decided that he is going to move the implementation of this universal health insurance scheme up by 5 years. Because at the time, in 1986, they say, okay, we're going to think about it, plan for it, and then implement it in 2000. But he said, no, let's do it in 1995. Lucky that he did this, because remember what happened in 1997? The big Asian financial crisis. That affected all of the economies in Asia in particular, but also globally. Taiwan was affected. It wasn't part of the crisis, but it was affected. So GDP growth slowed down in 1997 through 98, 99. So had they waited till 2000, they may have said, oh, you know, we may not be able to afford it, let's wait. But so Taiwan was very lucky there. Now, before the NHI, people ask, what was there? There were 13 different social insurance schemes, and 41% of the people did not have health insurance, and they are the vulnerable populations: women, children, elderly, retired, unemployed. But then, on 1995, March 1, this whole program went into implementation. And overnight, everybody became eligible to be insured. And by the end of that year, they managed to enroll 92% of the population, which is very impressive, I thought. But everybody, all the people involved in this, that's a whole nother story. Very touching, moving, and impressive. They went out, you know, into households, alleys, and say, oh, grandma, please enroll, you know, you're eligible, and be protected. And people enrolled. I want to ask this question: how did Taiwan decide to go single payer? I think, you know, it was this man, Reinhart, a Princeton man. He was born German and immigrated to Canada. He was Canadian. Okay? He went to the University of Saskatchewan, and he loved his years in Canada. They were hard for him because he was a poor person, but they built his character, let's say. And then he left for America for graduate studies, because his professor said, no, you shouldn't go work for a company, go study, do graduate studies. So he went to Yale, and from there he went to Princeton. So the idea to go single payer was recommended by Uwe in 1989. I remember he and I were in the hotel in Taipei. Didn't get much sleep. We just discussed single payer, multiplayer, HMO, or whatever. So in the end, we said, okay, single payer makes the most sense. And so he was the official high-level government advisor. So he said, okay, let's single payer. And that was when the framework was being drawn up, stage 1 planning. So I would like to dedicate this talk to Uwe Reinhart. So at the time, though, nobody understood or know what a single payer is. So they said, okay, how do you get the idea across and explain it? So he actually drew a diagram to show. So there are alternative financial arrangements between patients and providers and third-party payers, right? The three blocks, squares you see. On the top is one kind of organization, and the bottom is another. See? Here, Into those boxes, you have the enrollees or the insured who either through paying taxes or premiums pay, and that finances the program. And then the money goes into a risk pool. That's all the same. All the money goes in the pool for both type of arrangements, up and down. And then you have, this is the top one. You see these many pipes going up from the risk pool, going to the provider pool. That's on the upper right corner box. That's providers. So you pay providers through multi-channels. That's the way America pays. And we all know how complicated, complex that is. And also, it is a major reason why the United States healthcare is so expensive. Because just think of the administrative cost running a multi-payer system like that. Whereas in a single payer system, you got one payer that pays all the providers. And Uwe was really proud of this. He said, there's a control valve. You can play with that valve. You know, when the money is tight, you can turn it tighter. When there's more money, you can let it, more money flow through. So that's the secret of the single payer system. Yes, one payer with a control valve on spending. Okay, let's see how this system actually works. We'll first look at the national health insurance overall, what that looks like. So it's a government-run system. It's social health insurance. The NHIA stands for National Health Insurance Administration. So it is the single government agency that runs this program, headquarters in capital Taipei, and through 6 regional offices. You know, you cut up Taiwan into 6 regions, but the dragon's head is in Taipei. There's a mandate, all citizens plus legal residents. Look at this. In 2017, total national health spending was 6.1. I got this number last week from the National Health Insurance Administration. It's not even in the reports yet, but that's what they're spending. Per capita is 3,000. And the delivery system is a largely private one. And you can see that 85% hospitals private. All the clinics are private. They're solo. Most of them are solo. But slowly, there are more multi-specialty clinics today. And beds also predominantly private. Now this program is very affordable. People pay, the premium rate is 4.69% of your income you pay, but it's on a per capita basis. But for, say, if your household, say if my household has 8 people, you only pay 3. Anybody over 3, including, no, not including, so it's 4. The insured plus 3 dependents, you pay premium at this rate, but all the rest go free. And then in 2013, they needed more money, so they implement, and plus they wanted to improve the fairness in financial contributions, because this main premium is based on salary income, but then there are all these other incomes that was not in it to pay. So the government says we're going to start to assess a little bit of premium on those incomes, 6 sources like rent, dividends, not yet capital gains, bonuses, 6 of them.
What if you're unemployed? What if you're unemployed and have no income?
I'll come to that. Then the government helps you. And government set prices, and people can go have complete free choice of providers. There's no gatekeeper system. You can go wherever you want, however many times you want, in a day, usually, or a week or month or whatever. And most providers, 93% of providers, contract with the NHI administration. You have signed a contract, 3 years, renewable, unless you did something egregious, like committing fraud and abuse, then you may be, suspended. And most people pay their premiums on time. Okay, 99% of people. When you have trouble paying, you tell the government, and the government could arrange interest-free loans or refer you to a charity organization for help. If you're really poor, the government actually pays for your premium. The benefits, okay, what does it cover? It is comprehensive. One of the ministers told me, and it's in writing, because he said, it's so comprehensive that it includes all the mountains and all the oceans on Earth. Okay, it's inpatient care, outpatient care, drugs, dental care, which Canada's Medicare does not yet offer. I hope someday it does. Traditional Chinese medicine, prenatal care, daycare for the mentally ill. Then there's also, of course, mental health in and outpatient care, home nursing, palliative dialysis, all of that. But you do have pay a little bit of co-pays and co-insurance, but there are ceilings. And then there's more to this later. Here is the later. If you have any one or more of the 30 conditions, you do not pay any copay. And this is because they do not want people who are already suffering from illness or certain conditions to have any kind of financial barrier to needed care. And then what really makes this whole system sing is a very powerful IT system. It's highly administratively efficient, and we'll talk about that, more on that later too. So that was the overview, and now we can take a systems view of the national health insurance and looking at the 4 building blocks of any health insurance system. You have financing, and you have risk pooling, and then paying providers and the delivery system. We look at each one of these. Okay, where does the NHI get its money? Who pays into that risk pool? 3 parties: government, employers, and households. Okay, and these are the shares that they pay. Government about 34%, employers pay about 30%, and the rest is paid by household. And they divide their population into 6 categories. This is a little bit cumbersome, but it's worked so far. And I don't want to go through this slide other than to point out that for low-income households, there are actually now the number is about 3 million people. The government pays 100% of your premium. So you don't have financial barriers to care. Like, in the United States, we have so many people who are withholding care, or who not just withholding, they just say, I can't go. Even those insured, they still say the co-pays and co-insurance are so expensive that I won't go. But in Taiwan, that is not the case. Risk pooling is simple, right? Because all that money collected goes into a single pool. And pre-existing conditions, it was a big thing of discussion in the US right now. They wanted to charge the sick, Republicans wanted to charge the sick people more money because they say they're more expensive to care for. But in Taiwan, that doesn't matter. And you're insured for life. You can't get out, right? Because there's a mandate, so it's for life. And there's no threshold, so to speak. And it's not like in the UK NHS. I hope that none of you is from England, because they'll say, no, we don't have any threshold, but we all know that it does. It's around 30,000 pounds per QALY, right? If you go over that, then chances are that the NHS would not cover it because the budget does not permit it. Yeah, and the government subsidy for the poor, so that the poor are in the risk pool. It's just that the money, the government's money goes into that risk pool. Next, paying providers. Providers get their revenues from three sources. The biggest of the sources is, of course, payment from NHIA, which sets their fees. So there's a variety of ways that they get paid: fee-for-service, DRGs, case, bundled payments, pay for performance, capitation. They're trying that. And patient also pay a small user fee. When you show up at a doctor's office, you pay a registration fee, but it's like a few dollars. Maybe, you know, if you go to a basic clinic, you pay 50 NT, divide that by 30, it's like $1.70 US dollars to go see a doctor. But then there is copay and co-insurance, but then there is ceilings that protect you. And then if you have one of the 30 conditions, you don't pay any of that. And then, of course, the providers can, they get money from selling you products and services that's not covered by NHI, which is actually very, very few, because the NHI really does cover everything. But they may say things such as, oh, the NHI pays for this drug, but there's this other drug, drug B, that is much better. But then you pay, right? So this is how they earn extra income. And so we call this SID, Supplier Induced Demand, SID. That is a potential risk for Taiwan system. So I want to say that this kind of payment system actually makes things very equitable for everybody, because the fee schedule is uniform. It's not like you know, Dr. A charges this much, but Dr. B says, well, I'm more senior, so I can charge you more. No, they get paid the same. And the fees vary only by the level of different levels of provider organization. Say a tertiary center, their fees are higher than a regional hospital, which is then higher than a local hospital, etc. So what this means is that the patient's socioeconomic status does not matter. You can be poor. See, the doctor wouldn't even know. See, because in where I live, in Princeton, New Jersey, the private pediatrician's office used to have a sign on their countertop that says, we do not accept Medicaid patients. But in Taiwan, everybody gets seen. And their doctors' hospitals, they're not allowed to accept commissions, and they're on tests, diagnostics, or drug prescriptions. And they're not allowed to balance bill. You cannot say that, you know, I charge you extra because I am senior, I am good, or whatever, except for a few things like intraocular lens implants. You know, there are these some very fancy ones, bifocal, trifocal, whatever, that's more expensive, and the NHI doesn't pay for that. The NHI pays for models that are cost effective, okay? Like drug-eluting stents also. By the way, there's no evidence that drug-eluting stents extends life. There isn't. Artificial knees, just a few. I listed 4, maybe now there are 6. So what about the delivery system? Very easy access, right? This is, again, from this same health minister who told me this personally. 85% of patients reach hospitals and clinics in less than 10 minutes. I mean, no, 30 minutes. Because it's so convenient. Say I go out of the door of this building, maybe 20 meters to my left or to my right, there will be some kind of clinic. I can just.
The area of Taiwan, how big is it?
How big?
Yeah.
Geographically?
Yeah.
Oh, I mean, it's tiny relative to Canada, compared to Canada.
Okay.
I once did a calculation, I don't know if it's accurate. Taiwan is something like 1/264 of China's size. It's tiny. If this is China, Taiwan is here, like this, sits here, okay? So that makes it very, very accessible in terms of access to care. It's highly urbanized too. And waiting time, the majority of patients, over 80%, they wait less than 30 minutes. I have seen this because I would sneak into clinics and I would sit there and see who comes in and how long they wait, and that is really true. You sit there, less than 30 minutes, you get called in to see your doctor. And here are some real numbers. I got this from the government. Cataract surgery, the wait time, 11 days. It could be faster too. A total knee replacement, 17 days. Total hip replacements, 12 days. Okay, I have comparable numbers for Canada. That's in an article I just published last week in Health Affairs. Canada is something like 79 days, 80 some days for these procedures.
Just a caution, you have to be careful about when you're starting your wait time. Because
True.
What happens in some of them is they don't start it until they're basically ready. So the international comparisons get tricky because they don't
Yeah.
measure it the same way.
That is, yes, point is well taken, but still 11 days versus 79 days,
But I mean,
there's a big,
I'll give you one stupid example. Is years ago, my husband was starting to have cataracts, and went to the doctor. And the doctor says, "You're going to need cataract surgery, but you don't need it yet." 3 years later, it got to the point where he needed it. He got it quite quickly, but by the way we measure wait list, he was on the wait list for 3 years because he was seen by the same doctor who he'd been seeing before.
yeah.
So with a lot of the wait list things, that was the problem with it, is that the way they measured it was when you first saw the doctor rather than when the doctor thought you needed the procedure.
I agree with you. It's just like in cancer survival rates, right? 5-year survival. It really, that length depends on how early you are diagnosed.
So it's just if you're going to be giving presentations and doing it, you've got to be careful because you're sometimes comparing apples and oranges.
Right.
Greg knows that too. I mean, the
Yeah.
wait list strategy
Yeah.
ran into that as a big problem.
No, I mean, there's no, just that because I'm from the U.S. originally, and there's definite gaming of the wait time. So if I want to, if I'm a surgeon and I want to do more knee replacements, it's in my interest to show a long wait time so that I can then march to the government and say, you see, I have long, and so I think there is some manipulation of the numbers, but I think.
Yeah.
Yeah.
Right. Utilization, very high, very high. 12 visits per person per year, the average. The Canada I looked up, yours is 7.7 in 2017. That's OECD. That's what that table shows. Length of stay tend to be much longer, 10 days. And for people who live in remote areas, mountainous areas, offshore islands, there's IDS stands for Integrated Delivery System, that they bring the care to you. And so there are these helicopter deliveries, right? So if a pregnant woman is ready to deliver or in labor, they'll fly the mother and the belly to where there's a hospital to deliver. Yeah, I mentioned there's pilot on capitation. But so far, people like their freedom to go wherever they want to go, whenever they want to go. Okay, now let's see how it has performed. First, this is the OECD, the famous OECD chart. Ups, and I knew I'd get in trouble. Okay, I won't use it. See, you can see, right? That red bar there, everybody knows who that is. So Canada is there, 10.4, 2017. This is all OECD. The OECD average is 8.8%, okay? And Taiwan is not OECD, but I plugged it in there, 6.1. So it's done well. And then I did this. You can see Taiwan and Canada. And the interesting thing about this is the slope of that upward line, right? There, Switzerland's health spending actually has gone up steeply. It's now something like 12.5%. And Canada is right there. You know, I don't know how you would interpret this. You know, Gregory, you can explain that to me later. But Taiwan shows pretty even growth.
One of the things is I use some of it. It's also a function of how the economy was doing, because when the GDP wasn't growing,
Right.
it went up
Of
as
course.
a proportion of GDP.
Of course.
So
Of course.
That's not a portion of GDP, that's straight, so
Yeah.
in that case, it's more a matter of governments continuing to spend
Yeah.
at a fairly high rate even with an economic downturn, but only at the beginning of the cycle and then basically turning the lever off towards the middle
Yeah.
or the end of the cycle.
Right, right. You know, I have a graph showing OECD at the 2008 financial crisis on OECD. You know, you can see that spending would be going like this, but then 2008-9, there's a nosedive to zero growth. So you can either say, well, they control their spending well, or you can say they turned the valve. Right? So, yeah, there is that. So then the two highlighted columns are, again, Taiwan and Canada. So Taiwan hovers in the 6% range, and Canada in the about 10%, 10.5. As I mentioned that they protect their sick and disadvantaged very well. And I think we talked about all this, right? Premium copay exemptions, ceilings for copays, and premium subsidies, and IDS for the disadvantaged populations. Okay, now this is interesting. So how does Taiwan control health spending? It has controlled health spending very effectively, I would say, just looking at the more or less flat growth curve. First of all, spending cost control, it was a policy goal at the time that they established national health insurance. One reason was because health spending growth was very growing very rapidly. And then a very powerful tool that they have employed very effectively, global budget system, we'll see more of that. And then government fees, of course, and then the powerful IT system. It all goes together. So, capping spending with global budgets. They knew that in the 80s, OECD had tried, had used global budgets, and that's been shown to be effective to contain cost growth. Look at how health spending was growing rapidly before the NHI. This is my own calculation, just looking at their big table. I came up with 14 to 16% growth a year before the NHI. But as soon as the NHI was established, growth went down to 6 to 8% a year. You know, that's a big deal. Now, global budget, the law says yes, the NHI law says yes, you're supposed to begin global budget 5 years into the implementation. And Taiwan did that up to a certain point, up to 2002. Okay, you can see they introduced dental and Chinese medicine. These are the smaller. They started with the smaller sectors first, and then they introduced the primary care, which is 18% of the total NHI spending. But then in 2002, they needed to do hospital global budget, but there was huge resistance from the hospital community because, I mean, you can see how powerful they are. 63% of total spending was hospital spending. And so I actually remember the health minister at that time, it came to Princeton, and we met at night. You know, so what are we going to do because, you know, we're running deficits now. And so Uwe said, do global budget. You know, we just told him, and 2 months, so the minister went back, and 2 months later, hospital global budget was in. And I will show you, yeah, see, and I will show you what this did. I'll just finish this point. You can see, right? Here's the curve. Growth rate from 1997 to 2002, that was already NHI. The growth rate went down to 6 to 8% a year. But then from 2001 to, you can see that straight line growth, that is hospitals, okay? That's hospital sector. But then 2002, they implemented hospital global budget. You can see how that growth line flattened out, right? And then started to go down. So from 2003 all the way to 2014, the average annual rate of growth hovered around 3.4%, okay? Some years a little bit more, some years a little bit less. So you can see the power of these sectoral global budgets. Okay, you have a question.
Professor Cheng, when you say hospitals are private, who owns them?
Private entities, the largest private hospital system, you call them hospital chain, like the Hospital Corporation of America, HCA in America, they're owned by a great big conglomerate that started out in the plastics business. Yeah. So then,
So they're for profit.
their plastics business is for profit, but private hospitals are not for profit, okay? But says who? I mean, you know, Uwe will be the first one to say, if you look at the behavior of the for-profits and not-for-profits, there's very little difference. There's huge profit in non-profit hospitals because, among other things, you know, they can, the mother corporation can sell its huge delivery system, all the supplies, right? And lease the land on which these facilities sit, etc. There are ways, so they're hugely profitable. And the bigger you are, the more profitable. Yeah?
Could you explain a little bit about, at operational level, how did the hospital contain the cost? Because from my understanding is that there's no kind of referral system, so patients can just turn up to the hospital.
Right.
So there would be lots of requests from patients. While there's a global budget, I think the hospitals had to prioritize their operation on one rather than the other, etc. So, but which might be against the kind of overall coverage of the health insurance system.
Right. You know, that is something that I keep a close watch on, that I always ask, does your global budget interfere with access to care? you know, whether you have studies that show that, you know, because people didn't get timely care because of your global budget, that this and that happened. From both within the government and outside, I'm told no. No. It doesn't. Your surgery may be delayed. How are we doing with
No,
time?
I'm just saying, we can go, we started late because of the weather, so we're gonna go later. But what I'm going to recommend, because there's still a fair amount of material to go through, is that May go through the slides and the presentation, and we'll hold all questions till the end, and whatever time we have left over, we'll ask them. So please stick around a bit longer if you can. Thank you.
Thank you, Greg. Okay, so very powerful IT system. Hit the ground running. They knew this, so they made preparations for it. Very simple, efficient administration. The administrative cost is less than 1%, 0.77. That's the official number I got last week from the NHI administration. This is for 2019, 0.77%. And they have a staff under 3,000 that runs that whole system. Okay? It's all electronic processing, automatic claims auditing, and bills are paid quickly. Within 15 days you're paid, but then if something is found on the audit process, then the provider is contacted. And then if a billing is unjustified, they have to spit it back to the government, okay? Everybody carries a card, like a credit card you use for shopping. They use this card to shop for healthcare. It carries your personal information, your simple record, your 6 most recent visits, your major diagnosis, if you're hypertensive, if you're hemophiliac, you know, what drugs are you taking, what allergies you have, organ donation instructions, or you can say, do not resuscitate. You can state it on this card. They say, you know, if I'm in a traffic accident, do not resuscitate me, let me go. And they have to obey that. So you can see that this card then makes it very simple to run the system. It's very, very convenient for the patients, and the public loves it. 90% over, 90% satisfaction. And for the government who is paying, this is very powerful because the government monitors utilization on the patient's part. It also monitors delivery on the provider's part. So in other words, you can do patient profiling and provider profiling because the reporting system is very efficient. In theory, they're supposed to report every 24 hours what you did for which patient, okay? So the government knows spending in real time, almost real time. And then, of course, if the government sees, you know, that there's a surge in visits to clinics or hospital emergency rooms, it looks into it, there's some kind of flu epidemic or anything else, bird flu. And you can go on the web, patients, to look for, these are, you know, the government makes it possible for the public to look for quality and shop with this kind of information. And this is, I just went on the web, I said, is this true? And so I went on the web, and this is what I found. OR, what is it? OR is what? Visits, emergency, ER, it should be ER, emergency room visits, and hospitalization 2 days post-ambulatory surgery, okay? You wanna know which hospital have what kind of record, have higher readmission rates. So you go on the web, these columns represent see, one represents the names, and then names of hospitals and their IDs, and then it gives you their hospital readmission rates. Yeah. And likewise, you can say, well, I want to know about hospital infection rates because I needed surgery. I don't want to get hospital-acquired infections. You can do the same. Just put in what you're searching for. You get information like this. And then a few years ago, 2013 or 14, they introduced this Pharma Cloud. They wanted to keep track of duplicative prescriptions because remember, patients are free to go to any doctor. So I may go to you today, and in the morning I may go to you in the afternoon to say, and then you prescribe me the same things, right? And then I can do that with what I want. But a lot of them just, people throw out bagfuls of prescription drugs that they don't use because of overlapping prescriptions. So you can see this chart shows you how once they introduce the MediCloud, where all your prescriptions are uploaded on the cloud, right? How the repeat duplicate prescriptions went down, way down. And this has resulted in real savings. Real savings, okay? Plus, it improves patient safety, right? Because now the doctors are required to say, when a patient comes to see him or her, to look in the computer, what has this patient been given in terms of drugs? And then so say, okay, I shouldn't go there because already that patient has it. Or to say, if I want to prescribe this drug, I want to check against what he's already taking to adverse or minimize drug interaction adverse events. And then a year or so later, they introduced this. It's called My eHealth Bank. It's a personal health record. What it does is that it gives you 3 years of your own personal medical data. When you went to see whom, and what was your diagnosis, what were the instructions. And it even gives you your risk analysis, CKD, chronic kidney disease, and let you know what risk category you're in so that you can better manage your own health, right? And here it gives you your dental record. You had, say, this molar fix on this date, that teeth did something done to it on another day. It gives you a record of that. And then over there, it gives you links to sites for information that are trustworthy. So all of this is intended to help the patient manage their own health. I think this is awesome. Then the latest thing is, in 2016, this very ambitious a new head of the NHI introduced a MediCloud system. It's again a cloud-based system that provides doctors with patients' medical data to ensure drug safety and enhance healthcare quality. So doctors, hospitals use this online system to look at all of the patient's record. I'll show you what it all looks at. Medications, surgeries, tests, exams, drug allergies, etc., and even images, okay? And this is what it all shows you. Can you read? These are the categories of data, medical record, that's on this MediCloud. So that now a patient, say after going to one hospital, decides to go to another hospital for a second opinion or something. So this second hospital is supposed to look at this and see all that's been done for the patient, right? So that it will not say, oh, you need a new MRI, or you need this lab test and this. And this results in, of course, savings, cost savings, but again, also patient safety and quality, right? Because, imaging has its potential harms. This is very powerful. See, the provider, through a VPN system, gets to see all of this. CTs, MRIs, ultrasound, X-rays, endoscopy. In Taiwan, they do a lot of endoscopy checks for stomach cancer, esophageal cancers. Okay, so how do people feel about the system? Very high satisfaction. The latest one, this one goes to 2018, that's right. As of the end of 2018, last year, 86.5% satisfaction. Okay? I mean, the dips in satisfaction, that corresponds with when the premium rate went up and people didn't quite like it. But then you can see very quickly the satisfaction recovers. So now we look at the challenges. I think this list here, rising NCDs, long-term care, rising demand for new technology, etc., aging, workforce issues, financial status, that's like a template. Every health system has the same set of problems. So I will just quickly touch upon the three: the aging and the workforce and the financial status. The reason I mention aging is that Taiwan's population right now is young compared to OECD countries, younger than Canada, much younger than Japan, right? But in 2025, in what, 5 years, shortly, 25%, a quarter of Taiwan's population will be 65 and older. And why is that significant? Because as of now already, the elderly population, they're consuming close to 36% of the total national health spending, right? So as their numbers go up, you can expect this spending number to go up too. And the ratio of medical cost between the young and the 65-year-old and older is 1 to 4.6. And this graph really tells you a story. Just look at that turquoise line. You can see that, right? That tops every other country in the OECD by 2050 and 60. Because you can see the climb, the climb in the number of elderly, 65 and older, starts to climb about 2015, 14, 15. Right, the curve began to be much sharper upward, and then it surpasses Japan, the aging process, later. So that's a very, very serious problem. It causes all kinds of social issues. And then, of course, we talked about how well the government looks after the sick and the disadvantaged, but at a very high cost. Right now, that population, as defined by the NHI, is roughly 4% of the population, but then they consume 27% of the total national health spending. So I always say, can they continue to be as generous? So I propose that they start doing means testing, because now a multimillionaire, a Warren Buffett of Taiwan, gets exempted from copays, for example, and that probably shouldn't be. Warren Buffett will be the first to agree. Okay, long-term financial feasibility, stability. Yeah, feasibility, stability. Let's look. Here is a total picture of the financial status history of the NHI, starting with 1995 to 2014, but that pretty much, that changed a little bit. I'll talk about that. You can see that there was a surplus the first 3 years, and that is because of actuarial calculation that they took in more money than they spent for the first 3 years of the NHI. But ever since then, from 1997 on, you can see that it ran a deficit. The dotted green line is a deficit, is a spending line, and the solid blue is the revenue line. You can see that spending continued to be just above the revenue line, up till 2010. You can see the large gap around that time, and the government said, this cannot continue, so they raised the premium rate at that time. And immediately, now it works. Immediately, because of the higher premium rate, revenue went up, right? It went all the way up. And spending continued on this slope. So this area here means surplus, right? Surplus. Nice, wonderful. So finally, they're very, very healthy financially. And here you can see the first 3 years, right, they had the surplus dwindle, and from 97 to 98 begins to show deficit, and here shows a little bit of okay, but here huge deficit. This is when the health minister said, what are we going to do? This cannot go on, right? So then they put in global budget this year, and that helped a lot. But then, so there was a premium rate increase in 2002. That was the first increase in the 7 years of NHI history. But then they knew at the time that it will only be good for 2 years, right? So then year 3, again, deficit began to build. So then they did all kinds of things to cut spending, like they would cut drug prices and all this. So, but then they couldn't stop the leak. Look at the deficits here. By 2009, I did a calculation once. At that time, their deficit was like 15% of the total annual NHI spending. And this is just not sustainable. So this is when the government decided to do their second premium rate increase. And look what that did right away, right? So in 2 years, they paid off all the debt. They wiped out the deficit and built up this nice surplus that we saw, that big area of surplus. So the question is, what did the government do with this nice surplus? What happened afterwards? Do you live happily ever after? Not quite. Not quite. So this is the government's response to the buildup of the surplus. First, they reduced the premium rate from this to this. Okay? Second, they reduced the supplemental premium rate from 2 to 1.91. But then, third, they raised the floor for supplemental premium levying from 5,000 NT to 20,000 NT, a fourfold increase. So anything under 20, you now don't have to pay any supplemental premium on. So from that point on, the NHI started to live on borrowed time. Okay? So I got an email from a former head of the National Health Insurance just 3 days ago. He said, we're going to have a financial crisis in 2021. I said, what do you mean? I mean, I don't see any macro economic signs that Taiwan is headed into a financial crisis. Then he came back with some explanation. Yeah, February 9. He sent me an email, and this is what he said. Just look at the white. NHI turned deficit in 2017. Okay, because by then they started spending down the reserve, the surplus. So the deficit will increase every year as our premium annual growth rate is less than our cost growth rate. And by the end of 2020, according to the report, there's a report, they need to raise premium rate by more than 20%. Okay? Which is unprecedented in history. It's huge. So the question is, how are they going to manage that politically. Politically. See, that's why I call it crisis. Don't you agree? Yes, I agree. And you will all agree, I think. This is the report that he sent me. And so I looked through this report. It's very dense. So here's the basic point is that there is a structural balance in the financing. That there's every year between 2017 and 21, annual deficit of 3.26 percentage points. And that gap is growing. So that is that situation. So what is it? So I'm going to end the talk here, but let's look at what are the takeaways. Every other developed nation and emerging market economy now faces the same set of challenges in healthcare. I mean, that's just a given. And depending on their social ethic, their system of governance, and the resulting structure of their health system, some nations will cope with these challenges more successfully than others. And that, I think we all agree. And Taiwan's low health spending puts it in the very enviable position that it has the ability to pay more, for far more, which was what Uwe and I have been telling them to do for years and years. You can afford to spend more, a lot more, for health care. But the real question, and that's their biggest challenge, is whether they have the willingness to pay for more, whether will be the public's willingness, the political leadership, and all of that. So that will be their coming biggest challenge. But then, having closely observed Taiwan's national health insurance, I believe that Taiwan will be among the more successful nations and economies in managing their healthcare system. So I guess fundamentally I am optimistic as of now. So it's got a huge challenge. Whoever becomes the next president, it'll be next year, 2020. They elect a new president in March. So the challenge is now. So thank you very much.